let's move on to monoclonal antibodies, specifically in squamous cell patients. I mean, we think about monoclonal antibodies in lung cancer, and of course, we all turn to bevacizumab, a drug that has shown efficacy and survival advantages in the non-squamous patient population. But toxicity signals perhaps wrongly characterized in the squamous cell population. Maybe it wasn't the squamous cells that really predicted toxicity to this drug. Nevertheless, bevacizumab is not approved in the squamous cell population. Things have changed now. We have two new monoclonal antibodies that are approved, one specifically in combination with platinum frontline, nesitubimab, in a squamous cell population. And the other is ramucirumab, which we have to remember included a fair number of squamous cell patients, that the benefit was there as well. So I want to talk a little bit about these two drugs because it's more options for our patients, both in the frontline setting and the chemo-refractory setting, and maybe put these in context, at least for the second line, with immunotherapy. So Paul, you want to talk a little bit about nesitubimab, how it works, and the Squire data that got nesitubimab approved by the FDA?
Sure. So the regimen of cisplatin, gemcitabine, and nesitubimab is built actually on a foundation of work that's been going on dating back to original reasons to target EGFR in non-small cell lung cancer starting in the late 90s with protein overexpression. So nesitubimab is a fully humanized monoclonal antibody against the EGF receptor. Its predecessor, cetuximab, was a chimeric antibody for which we have data from the FLEX trial. And the FLEX trial subset analyses were promising. Among other subgroups that showed improved efficacy, we'll get into the H score a little bit for EGFR expression, but squamous lung cancer came in the subset analyses as a group that seemed to have more benefit than non-squamous patients. And this was the backbone and rationale, particularly in conjunction with EGFR overexpression, for the Squire study. So the Squire study was a randomized phase 3 trial of cisplatin, gemcitabine, and placebo versus cisplatin, gemcitabine, and nesitubimab. Nesitubimab was continued as a maintenance therapy for patients who had at least stable disease on the regimen. And the data were presented first at ASCO a couple years ago, published last year in Lancet Oncology, and shows that there was some modest improvement. And I think most of us would classify it as modest improvement in terms of overall survival and PFS benefit. Hazard ratios that hovered around 0.85 essentially for both PFS and OS. For a first-line regimen, certainly something that's not the solution, and particularly in the face of the hazard ratios and benefits that we saw with nivolumab in the second-line setting against docetaxel also makes it look a little bit less compelling. But the data are the data, and this is data that led to an FDA approval indication, in part because there really is nothing competing in the first-line setting for something that's similar, and because the thought is that though the results were modest, there's still some small amount forward. And so that decision has been made. The response rate's important to note was not significantly different, right. Also essentially in the low 30s, which again, if you put the regimen side by side, is still a lot less than carboplatin Abraxane if we put that next to it.
Now, are you using nesitubimab? I mean, you clearly, as you've said, shown that there's an FDA approval now. There was a modest but significantly different overall survival advantage between the two arms with the addition of nesitubimab. Using it on a day-to-day basis, reserving it for patients? If so, which patients? Is there a role for this drug, routine clinical use?
Yeah, it's hard to know because we'd like to have a good reason to give something, some specific clinical situation where the data are going to be able to guide you. We should give this, particularly as we said, in a landscape that doesn't have a lot of head-to-head comparisons. The problem is that giving this requires giving cisplatin. Which not all of our patients are eligible for any number of different reasons. The side effect profile also is a little bit worse, of course, than cisplatin and gemcitabine, as we saw, which gave some concern. In addition to that, while the overall survival benefit is the most compelling, that's a little bit hard to frame on an individual patient level, as we've been talking about, an individualized level. While response rate is easier to conceptualize as important, and to select for in any given patient. Overall survival based on a median is a little more abstract. Right. And so that's a little bit more challenging in terms of selecting. So as a result, I do believe it will be a niche thing. I think for anyone in whom we are considering cisplatin gemcitabine, certainly the addition of necitumumab is there. Outside of that, it doesn't have a well-defined space, unfortunately.
Right. Ed, your thoughts on the NESI data?
You know, it's interesting. I think I've been as happy as I have been sad with the landscape in the last year or so. You know, we should be really excited that we have 4 drugs approved for squamous. And although we have one that's really popular, that we'll talk about later, the checkpoint inhibitor, one that's less popular, and 2 that are not popular at all, we've gone away from where our science is, and that's the biomarker. And we'll get into more of that later, obviously, but I'm one who likes to have options. I like when I walk into an ice cream store, I don't want just Neapolitan flavors. I want 35 to 100 flavors, and I want to be able to choose. And so I don't ever disparage approvals or indications because they're so inconsistent. Frankly, I would love to have cetuximab available, and based on the data in Flex, I thought it should be reasonable that it should be there. But we just placed necitumumab with cisgem into our pathways. It is an acceptable regimen. As Paul has stated, there are some challenges with it using cisplatin, and some people will freely sort of substitute that out or not. I do believe that there is a role, we just haven't really found it yet, with monoclonal antibodies to EGFR. The results have been less than spectacular in a lot of the subsets. Maybe there'll be a biomarker that arises that will make sense, but I think we can learn a lot from the checkpoint inhibitor that, again, the sort of the science is that unless the biomarker really drives decision making, it's gonna be tough to incorporate one. And I think that's the same thing we're going to have with EGFR antibodies. Unless you have a really definitive biomarker that separates a curve from a 60% response rate versus a 20% response rate, it's going to be hard to implement.
Right. So we'll get to the biomarker in a second. I think my impressions of this data, I agree with both of you. It's going to be hard. We have not used it routinely yet. I think the benefits are modest. I think some of the nice things about this study is that 10% of the patients who enrolled in the study were ECOG2, and this is kind of representative of some of the patients I see, so it's at least tolerable in this patient population. It did employ a maintenance approach in the experimental arm. We don't know if the benefit seen was due to the maintenance or the induction part, similar to the bevacizumab story, but certainly showed a benefit for the first time ever, I believe, in a squamous, specifically in a frontline setting with a platinum doublet, showing an overall survival advantage. I think, to touch upon your point, however, the lack of a molecular enrichment strategy is key here, and I agree. I think if we're going to use these drugs, if we had a predictive biomarker, that would help us out a lot. And I think that there have been efforts. I think at least at the time of publication of the study, they had looked at H-score. It did not turn out to be statistically significant like it had in the Flex data with cetuximab. But more recently, there has been a presentation on EGFR copy number by Fish at World Lung that may glean a little bit of insight into who is going to respond or who's going to do better with NESI. Paul, you want to talk about that
Yeah,
biomarker?
it's not surprising. So the H-score, H-score is always difficult because the cutoff is a little bit arbitrary, right, in terms of a 0 to 300 scale. And the cutoff they had used was 200. Right. And there was not a significant interaction between the two groups that panned out. It's the nature of H-scores. EGFR copy number has a similar problem because it's a continuous variable. At least in terms of the biology, it may conceivably make sense also. I mean, it's something that should translate into protein overexpression also. And there was, as you had said, some signal that a higher EGFR copy number may predict for response. EGFR amplification by itself occurs maybe at most about 10% of squamous lung cancer patients. So there's a lot of overexpression, but the copy number in terms of amplification happens in a subset of patients. And so I do think, as you had mentioned, really focusing on these subgroups that make sense and then seeing it out is really going to have a lot of benefit and will help everyone academic oncologists, community oncologists really figure out whether or not this has a specific niche for that population. But again, it's a small subset. It's going to be difficult to sort of see this to its end, I think.
Yeah, I think we're still missing that. We're still missing the molecular enrichment strategy. I think we're hungry for that in this era of personalized medicine and targeted therapies where we wed targeted drugs to actionable mutations. I think that's what we're looking for. So.